Oh, we were hoping you'd send some medics.
Really? But we're the United States of America. The military is all we have.
The Ebola epidemic was handled rather badly. Now the same sorts of mistakes are being made with the response to the coronavirus. I'm going to have a little look at the ways of thinking that led to some of these mistakes, how they're being repeated, and what could be done differently. Woo! The first cases of the Ebola epidemic were in Guinea in December 2013 and were initially treated by the humanitarian organisation MSF. During the first few months, there was little involvement by the state or larger international organisations. In the beginning, we did as we wanted. You talked to 2 or 3 people from the Ministry of Health and you reacted. MSF's resources were overwhelmed, and by late March, with cases reported in Sierra Leone and Liberia, they declared that Ebola was actively transmitting in more than 60 locations and that local healthcare workers were dying by the dozen. They were largely ignored. The World Health Organization didn't declare Ebola a public health emergency of international concern until the end of August, once some Westerners had been infected. Stating that Ebola was a public health emergency didn't actually do all that much. So in September 2014, MSF decided to request help from military medics, who'd have been useful as some militaries had been looking into Ebola as a biological weapon for a little while. MSF aren't a pro-military organisation because, you know, they're sane, but since the epidemic was getting mightily out of hand, they thought that it was only a matter of time before Western militaries got involved, and they thought it was best to try and shape how the militaries acted. They didn't want any old gun people just standing around at checkpoints or whatever it is that military types like to do. MSF were clear that they wanted medics and logistical support, not quarantines and crowd control, but of the countries to send troops, only China sent mostly medics. Primarily foreign militaries played a role in logistics and the security of health workers, whilst domestic militaries took on roles like manning checkpoints, enforcing mandated burial practices, and crowd control, with some support from foreign militaries. The involvement of militaries introduced a series of military logics into the response to the epidemic, like belief in hierarchy, obedience, and the use of force. With this, many humanitarian agencies worried about becoming health police, and the president of MSF stated, "Countries are approaching this with the mindset of going to war. Zero risk, zero casualties." Over the following year, the regional governments and international organisations became much more involved with the crisis, rolling out their own bureaucratic methods for dealing with the epidemic and involving their appointed officials in decision-making processes. They mostly played a role in trying to regulate things, more because that's what they liked to do than because it benefited anyone affected by the epidemic. In the initial phases of the epidemic in Conakry, we had fewer difficulties. Since then, there are rules, regulations, but behind all that, where is the national sovereignty? This structuring, whilst well-intentioned, largely expanded a lot of time and energy to what we might call limited effect. It seemed as if most of this bureaucratisation was driven by the international organisations involved's own routines and administrative requirements, like situation reports, daily data and activity reports. Equally, such moves as this often tend to make governments on the African continent responsible for a humanitarian response which was largely out of their control, and was organised by international organisations who ended up using the involvement of local states as a means to absolve themselves from responsibility for their decisions and their own inefficient bureaucracies. An MSF doctor recounted how early on the WHO regional body blocked the appointment of a well-respected expert in hemorrhagic fevers in favour of an inexperienced colleague for petty political reasons. And how, once more money had come in towards the end of the crisis, he'd see brand new cars used for outreach work parked next to underpaid or unpaid and overworked local health workers who still hadn't received adequate training. Ebola has become a profitable emergency because it's generated a lot of fears across the developed north. So lots of money and lots of players, not always with the capacity to spend it, or at least as one should. If you compare the sums injected with the number of positive cases, it'll bring tears to your eyes. All for the 18th ranked disease in terms of the country's mortality rate. Let's just have a little break. Here's an animation of a crane because it's uplifting. Running against the themes of standard methods of bureaucratisation, the epidemic was also treated as an exception, a risk to state failure, a threat to regional and global security, and a potential of the virus spreading beyond the region. Thinking of the epidemic as exceptional led states and NGOs to give themselves the liberty to sidestep normal practices and regulations in favour of adopting fast and unchecked methods. Thinking of the epidemic as a series of risks to be contained led to many of these institutions focusing on possible future events rather than the mundane plethora of health problems in the present. These ideas of risk management got mixed up with ideas of securitisation. NGOs and governments tended to think along the lines that the virus posed a risk that needed to be contained, and the best way to do this was through quarantines and safe burial practices enforced by security forces, like the police and military. The primary concerns of humanitarian workers should be what security measures they took, along the lines of wearing personal protective equipment and interacting with the local population in ways that would allow them to easily withdraw if things started getting hostile. This was to be prioritised over what humanitarian workers are usually most interested in when they're left to their own devices: humanitarian work. Securitisation wasn't all that great of an approach. The military would set up checkpoints to enforce quarantines, but because people didn't trust them, they just used other paths to go round the roadblocks or take fever-suppressing drugs if the checkpoint was conducting health checks. People suspected of having Ebola were forcibly contained within Ebola treatment units to segregate them from the general population. This was done for a good reason. It's generally preferable not to have people running around infecting everyone else with Ebola. However, such policies somewhat misfired. Again, many people didn't trust the police and military who enforced such policies, mostly because of a recent history of mistreatment at the hands of such authorities, and thus were reluctant to get treatment. This not only impacted potential Ebola patients, but also those with other diseases, particularly malaria, which has similar symptoms. Many people with symptoms of malaria worried that they'd be wrongly sent to an Ebola treatment unit and then contract Ebola. In an effort to avoid dying of the extraordinary, you can end up dying of the mundane. There were almost as many additional deaths from malaria during the epidemic as there were from Ebola, maybe more. The combination of securitisation alienating people from healthcare provision and the focus on risk management rather than day-to-day healthcare led to a neglect of other diseases. During the Ebola epidemic, some people with HIV lost access to their antiretroviral drugs, leading to them no longer being virally suppressed, and thus being able to pass on the disease. The number of HIV-positive mothers coming to health facilities for treatment to prevent mother-to-child transmission decreased by 25% in Sierra Leone from May to September 2014. Such things are going to exacerbate healthcare problems in the region for decades. Okay, one more example of how securitisation is bad. The Red Cross recommended various security measures for team members entering villages for outreach. They were to park their vehicles in starting positions to quicken escape, and protective clothing was detachable so that it could be discarded to aid escape. These recommendations might have been useful, but they didn't exactly promote peaceful and positive interactions with the local population. Members of communities expressing their discontent or wanting answers to certain questions were often interpreted by healthcare workers as signs of reticence, justifying their withdrawal from the community. This would have led to increased distrust of health workers, hence more questions and discontent the next time they visited, and so on and so on. In 2014, in the town of Wome, residents murdered 8 people, Guinean journalists and health workers, who'd travelled there to conduct Ebola education and outreach. In the international press, this was mostly reported as an example of the villagers' ignorance. However, it's not that. That's, as you can kind of expect from the international press, a very stupid opinion. It's unclear why this violence flared up. A health worker on the team who survived suggests that regional political grievances heightened hostilities towards the team. The forest region of Guinea has suffered discrimination for decades from successive regimes, which might have led to certain interpretations of the acts of health workers. It's important to note how even the most benign of interventions can be rooted in longer local histories of how such interpretations have been interpreted. Public health interventions need to incorporate understanding and address more general local grievances if they're not going to constitute a top-down imposition of security measures. Security forces responded to this incident by occupying the area for over a month, sending the residents fleeing into the forest. There were many incidents like this, followed by many harsh crackdowns. I like this quote from Adia Benton. Security mobilised against communities experiencing profound distress may inspire acts of resistance. A heightened awareness of insecurity among aid workers may compel them to interpret overt challenges to their authority as a threat to their security. It may inspire further acts of defensiveness. Securitisation focuses on controlling future risks, which leads to future controls of future risks being extremely appealing, which makes technofixes like vaccines and surveillance technologies for quarantining and tracing contacts seem like the way to go. This is a bit silly. Basing your public health policy around the idea that you'll be able to invent some techno-magical solution to make the problem go away is probably not a good idea. Of course, vaccines are great when you've got them, and a series of technological innovations can really improve patient care, but still, assuming that someone will invent a thing to fix your problem soon, so that you don't have to worry about it, is all very silly. Did you notice that a lot of what I just talked about is currently being repeated in one way or another? If you did, then you can have a gold star. The Jehovah's Witnesses are getting really excited now that they know everyone's definitely home, and Rick Astley said that he'd put on a free concert for NHS workers once the lockdown is over. Though, personally, I think they've been through enough. The world's governments have jumped to the same logic of securitisation as they adopted in the Ebola epidemic, although the degree to which they focus on containment over care seems to be less. This is probably because coronavirus has affected the West, and white lives tend to be valued more highly than West African lives by Western governments. I think it's called racism. But I'm getting sidetracked. Most government policy and media attention is devoted to how the healthcare and economic risks of coronavirus can be managed, not to the healthcare needs and economic position of actual people in the present. For example, the UK government has released a series of rather rushed policies to help stop small and mid-sized businesses going bankrupt. However, they haven't really done the same for small, mid-sized or even big people. There's grants for small businesses in the hope of staving off an economic disaster from all the businesses going bankrupt. But there aren't grants for people who've lost their jobs or had their hours reduced who face the more personal disaster of taking on a load of debt, or of being evicted because they can't pay rent. Grants for small businesses are a good idea. It does a number of nice things like stopping an economic shift towards the big nasty corporations who are better placed to not collapse after a couple of months of not businessing. But the focus on risk by policymakers draws their attention away from more immediate personal problems which, you know, it would be nice if they also did something about. If you can give each small business tens of thousands of pounds in grants, then you could also give people some money which might help them out, and maybe that would be a system that you'd want to keep going forwards. Under a logic of securitisation, crisis management becomes a priority over considering who could be helped in the short term and what sorts of measures might be nice to keep for the long term. Okay, now let's look at healthcare provision. For the last decade, the UK government has been really into this thing where they claim that their austerity measures are bringing the national debt down, but regardless of that, the debt goes up. And okay, debt is a fairly abstract concept. Maybe it's open to interpretation, but now they're doing the same thing with mops. They've claimed that they have enough supplies of personal protective equipment and cleaning stuff, but this claim doesn't really stop hospitals running out of masks and mops and whatnot. And it becomes a lot harder for healthcare workers to safely provide good healthcare when they don't have the stuff they need to do that. Generally, when there's been an epidemic, it's been somewhere in the global south, so Western governments and medias have been able to blame the poor allocation of resources on third world corruption and underdeveloped healthcare systems, even though organisations like the WHO have been responsible for much of the bureaucratic structure and decision-making involved in such resource allocations. Now that we see how Western health systems don't deal all that well with a pandemic, maybe it's time to look at the problems of the bureaucracies of Western health systems, which have been responsible for the mismanagement of a lot of epidemics over the last few decades. Perhaps the top-heavy systems of resource allocation, with all their bureaucratic quirks, aren't that well suited to providing what's needed when needs rapidly change. Maybe we could look at more peer-to-peer methods of resource allocation, like those adopted by MSF in the initial period of the Ebola epidemic. An interesting exercise is to watch some news and see how they hardly mention the act of healthcare, or to look at how government policies hardly relate to this act. Sure, they'll talk about increasing hospital capacity, they'll interview doctors about how many patients they have, how they don't have enough equipment, how many patients are dying, but never the actual act of healthcare. Surely the main discussion around all this should be how to provide better healthcare, not just to scramble to provide more resources. A pandemic isn't a game of Catan. You don't just put 2 sheep and a log into the bank to cure the virus. Doctors and nurses are trying very hard to care for an overwhelming number of patients. Maybe more attention should be placed on how their efforts can be supported. And now let's have a look at quarantines. Earlier I talked about how securitisation didn't work in West Africa since many people didn't trust the government or security forces, so worked out their own ways to avoid security measures. This caused many people to avoid seeking healthcare. There's also a load of communities in the West who have some rather good reasons not to trust security forces, and securitising healthcare can really run the risk of alienating them. For example, in interviews, some homeless people expressed worries that the government scheme offering them hotel rooms for the next few weeks would end up being like prison. Equally, the lockdown doesn't seem to be all that effective. Some things have been shut down perhaps beyond the degree necessary, whilst people are still heading out just to buy a packet of French bean seeds or whatever. People either don't understand what a lockdown does, or don't see it as necessary, don't trust the authorities, or think that it shouldn't apply to them in particular for some reason or other. Second homeowners are sneaking across the North Wales border at night to avoid the police. Would it be more effective to perhaps put more effort into explaining to people what they should and shouldn't do and why they should avoid it, rather than setting up checkpoints or whatever? The current method seems to be that some authority kind of just tells you what to do and then expects you to do it. It's like being back in school or prison or hospital, as the meme goes. It's still unclear to a lot of people whether or not you should do this or that, or why you shouldn't do such and such, and maybe the focus should be on explaining rather than enforcing. If the police are going to be out doing something, then perhaps they could go around explaining these sorts of things to people. Although police uniforms are a bit intimidating, maybe they could wear a nice hat or something so they look a bit friendlier. Ideally, you'd use some trusted community members who don't have rather a tainted record of state-sanctioned violence. But societies are a bit atomised at the moment, and it's hard to tell who this could be. Vicars or imams for some people, I guess. Maybe teachers for others. Some enforcement of lockdowns might be needed, but it shouldn't be the default position. There's a lot of ways you can invent around the logics of securitisation and bureaucratisation. Such logics can be balanced with other ways of thinking. However, you probably can't just discard securitisation and risk management as a way of thinking. They've probably seeped into all of us to some extent, and after that you can't really ignore them. I really like that line from The Word for World is Forest, where people from Earth have begun to colonise a planet. One of the people who already lived there, Selva, then has to teach his people to kill in order to fight back. Once they've repelled the colonisers, Selva says to an anthropologist from Earth, sometimes a god comes. He brings a new way to do a thing, or a new thing to be done. A new kind of singing, or a new kind of death. When he has done this, it is done. You cannot take things that exist in the world and try to drive them back into the dream. That is insanity. What is, is. There is no use pretending now that we do not know how to kill one another. Stop, stop, stop. We can't have this. This philosophical musing is getting far too abstract. Anyway, thanks. Bye.